There are well-established endoscopic techniques for managing gastrointestinal bleeding. Until recently, there has been little consideration toward use of endoscopic ultrasound in the management of these patients. In this video, we present 4 patients who each developed clinically severe gastrointestinal bleeding that failed to respond to standard endoscopic techniques. The first patient was a 67-year-old gentleman who had chronic pancreatitis. He presented with a clinically significant bleed and received 14 units of packed red blood cells. His evaluation of the referring hospital failed to identify a source of bleeding. Following referral, the patient had 2 significant rebleeds. An EGD and colonoscopy failed to identify a source of bleeding. A CT of the abdomen was performed, demonstrating an enhancing pancreatic head structure representing a 5 by 3 centimeter pseudoaneurysm. At angiography, injection of the celiac trunk and superior mesenteric artery failed to reveal the source of bleeding. However, given the proximity with the pseudoaneurysm, the gastroduodenal artery was selectively cannulated. Embolization was then performed with the use of coils and gel foam. After another clinically significant bleed, angiography was repeated, but again a source of bleeding could not be identified and no therapy was provided. Surgical intervention was considered, but declined due to the presence of comorbid illnesses. An endoscopic ultrasound-guided intervention was then considered. Linear EUS was then performed with use of power Doppler, clearly demonstrating the point of communication between the pseudoaneurysm and the superior mesenteric artery. A 22-gauge needle was then inserted into the pseudoaneurysm and advanced to the site of the feeding vessel. 7 cc's of 99% alcohol was injected, and the echogenic appearing alcohol could be seen swirling within the pseudoaneurysm. With continued injection of alcohol, power Doppler was applied in an attempt to determine whether there was any impact of therapy on flow within the pseudoaneurysm. Over the following 20 minutes, blood flow within the pseudoaneurysm decreased, and eventually no flow was detected with power Doppler. The image on the left shows the initial pulsatile flow prior to fine needle injection, whereas the image on the right demonstrates cessation of flow following therapy. The patient was discharged 5 days following EUS. Follow-up CT demonstrated a thrombosed pseudoaneurysm without flow, and there's been no recurrence of bleeding over the subsequent 11 months following therapy. The second patient was a 67-year-old female with a history of valvular heart disease and atrial fibrillation, for which she received Coumadin. She had 4 bleeds over the prior 8 months and received 25 units of blood. Multiple EGDs were performed detecting fresh blood in the second portion of the duodenum, but no source of bleeding was found. Nevertheless, they randomly and diffusely applied heater probe and injection therapy. Initial EGD at our center was normal. Radial and linear imaging revealed a large caliber vessel extending directly to the duodenal wall, from which a smaller vessel branched and coursed to the mucosal surface. 2 separate fine needle injections were then performed, injecting a total of 4 cc's of 99% alcohol. Initially, the needle tip was directed at the point of branching between the larger caliber vessel and its duodenal wall branch. The initial injection was followed by another, more superficial injection. A band was then placed over the site of injection. Despite having 4 clinically significant bleeds over the prior 8 months, she has not developed any evidence of rebleed over the 18 months following therapy. The third patient was an 81-year-old female with colon cancer. She was evaluated at a referring hospital with CT that suggested infiltration of the colon cancer into the duodenal wall. At EGD, she was found to have a duodenal ulcer, and heater probe and injection therapy were applied. Following referral for continued bleeding, an EGD was performed revealing a duodenal ulcer with a visible vessel, and she was referred for EUS. Initial radial EUS examination revealed hypoechoic wall thickening in the site of the duodenal ulcer. It was felt as though this process did not result from direct infiltration of the colon cancer. Power Doppler demonstrates a thin tortuous branch extending from the gastroduodenal artery. The arterial flow within the gastroduodenal artery is demonstrated with pulse Doppler. This site was then targeted for fine needle injection of cyanoacrylate. 3 cc's was injected into the site of branching from the gastroduodenal artery. A right hemicolectomy was performed several days later. This confirmed the absence of malignant infiltration from the colon cancer to the duodenum, and the patient has had no recurrence of bleeding in the 9 months since therapy. The fourth patient was a 79-year-old female with a recently diagnosed hepatocellular carcinoma. She presented to an outlying hospital with a clinically significant bleed, and their evaluation and therapy included an EGD with the diagnosis of isolated gastric varix, for which fibrin was injected. As bleeding continued, she was transferred to our center. The patient rebled twice over the course of the hospitalization, requiring a total of 16 units of packed red blood cells. The patient had an actively bleeding lesion, and 7.5 cc's of cyanoacrylate was injected. This therapy failed to control the bleeding, and therefore an endoscopic ultrasound was scheduled. Initial EGD performed at the time of EUS revealed the changes resulting from prior interventions. A linear EUS exam also demonstrated the effects of prior injection therapy. However, EUS also demonstrated that the injection had in fact been directed toward the periphery of the lesion, and that the lesion likely represented a gastrointestinal stromal tumor and not a gastric varix. To confirm the suspected diagnosis, a true-cut biopsy was obtained, and on-site cytopathology review confirmed the diagnosis. Fine needle injection was then performed with use of 5 cc's of cyanoacrylate. The needle was advanced to the deepest extent of the lesion with constant injection applied as the needle was slowly withdrawn. Repeat endoscopy performed the following day demonstrated the effects of fine needle injection. No recurrence of bleeding occurred over the 6 months following therapy, at which time the patient died of unrelated causes. Certainly further study is necessary to determine the safety and efficacy of EUS in the management of patients with clinically significant GI bleeding with the goal of improving patient care and clinical outcomes. Thank you.